Me up here, both of you. I feel very undereducated and even less with clinical knowledge, but that's okay. We're talking IT a little bit here. So the first question of the study talked about the focus of organizations having 91% of the respondents focusing on interoperability and being part of their vision and strategy. So Emily, I'm going to start with you. What are you doing? What's your organization doing to deal with this? And is this part of your plan and strategy?
Yeah, it's a great first question because I feel like the word interoperability is like up for grabs. I don't know if that's true at your institution, but if it involves connecting one data source to another, people are like, it's interoperability, and it gets a stamp on it. So our team is pretty overwhelmed with requests for their services. As context, I already spoke a bit about where Riley Children's Health is. We are in the middle of Indiana, and similar to you all here, we have a very established health information exchange. Is about 20 years old. So for a long time, it's almost as if people didn't even know what they had. Now being asked to integrate with all the other different sources, the payer, the pharmacy, mental health services, health, various health departments within our state, it's just rising. So I would say I have kind of three big buckets where our strategy, and I use the word strategy very loosely. The strategy implies that it is a long term, and I feel like there's just so many new things coming in. We're going to have to adapt it. Three big buckets, though. I put the first one in regulatory elements, so things that we are required to do. Those pressures around things like you have to be able to send, this is like the old school interoperability, right? Those great CCDs that look like they're written by the EMR because they are, and someone gets them and they don't really tell you clinically what happened because it looks like, it looks exactly like what it was designed to be. That still's there, and kind of how you interpret those laws is still a big pressure. The second, which is kind of more exciting for me, is that it's very clinically focused. So under our interoperability strategy includes things like patients that come up to you and say, I want to plug in health records for iPhones. That's actually under our interoperability structure too. So to be technically geeky a little bit for a moment, understanding things like FHIR APIs, and we have to by law be ready to do those. Adjusting that's a second bucket. And then the third bucket is I feel like it's probably the thing that wasn't on interoperability roadmaps 5 years ago. It's things like Salesforce and generally groups that you didn't have a big, robust relationship with as a healthcare system. Does anyone know what Salesforce is? Do you guys? It's like a big old data, HR, people management company. And in 5 years ago, if someone said, well, you're going to have to figure out how to integrate Salesforce's data into your data and then try to decide what you want them to do with it, I think I would have said, really? That doesn't seem like it's imminent. But I would say those three big buckets are kind of where our strategy is being asked to respond to. And then a big asterisk that says, and probably some other things that have happened since we started talking.
That's great. Suresh?
Sure. Great talk, Chris, by the way. Very, very eye-opening. Going back to that really busy slide that you had, and I will urge my clinical colleagues in the room to take a look at it, which not only explains the complexity of interoperability, but also the scale and scope of it. And then going forward, when we start talking about social determinants of health, publicly available data, whether it's at the county level, state level, we will have an ask, we as in healthcare leaders will have an ask as to how do we integrate that data, because now there is evidence that that does improve care at point of care, follow-ups, etc. Specifically going back to your question, the two areas where I'll put my UPMC children's hat on now, where we are investing. Look at the question again. Where are the technology investments in your organization? One is you already mentioned interfaces between active EMRs, and I'll give a quick practical example. I'm an emergency physician. I see a patient in my ER. I document in the Cerner EHR. The patient follows up the next day in Children's Community Pediatrics, which is a primary care network, and they have Epic. I'm happy with my Cerner. They're happy with their Epic. It's unlikely to change. We'll keep it that way. But the physician, I'll pick Dr. David Wolfson, who's the medical director, when he sees the patient, the same patient, and documents in his Epic EHR, he does not have to get out of Epic, and he can see my note if I did it timely. in the Epic EHR as a PDF, and if the patient comes back to the ER, let's say, or to Children's Hospital a few days later, without getting out of Cerner, we'll be able to see Dr. Wilson's documentation. And that's a oversimplified version of a practical interface that Chris and his team have built, and there are lots of other examples. So going back to specifically answering the question, more similar interfaces. I know it's one-on-one, and you have lots of one-on-ones on the slide, but that's what clinicians will need. And this is just between two settings of clinical documentation, and then you have to add how does it work in the physical therapy clinic, how does it work from home, how does it work from another hospital, etc. So that slide is going to get more bigger. The second area where I'd mention specifically at Children's and for UPMC in general is investing in patient portals. And we strongly believe that they are a very critical component of consumer-driven care. You can call them personal health records. In fact, CMS and ONC say that you could use the terms interchangeably, patient portals as well as PHRs. And PHRs are not just for bill pay or online scheduling, especially for some of our children with complex health issues and chronic care. It's a great tool empowering families, and you can think about it as interoperability. We always think of the first thought when you talk about interoperability is doctor to doctor, hospital to hospital, health system to health system. But you could put all of that in one bucket, and then you have the patient or the family. And how do we connect those? And that's where portals come in. And they can do a ton of great things for the family, and it saves valuable time for the patient and family. I'm going to repeat that statement. It saves time for patient and family. So think about that. So that's worth an investment, putting it there when you have an informed patient or parent who is sitting in an ER or any exam room, opens up their phone, and I'll mention a data point. It has to be the phone, not the desktop, not a tablet. It's the phone, and open up their version of the EHR, so to speak, and track a child's hemoglobin, just as an example, and it empowers them a lot. So then they can ask better questions to the caregiver, and it's overall a win-win situation. So those are the areas where we are looking at as to where do we devote resources, time, effort, money, space, whatever it is, for improving interoperability.
Great. So Suresh, I'm going to stay with you with the second question here, just because I actually gave an example in my presentation about us getting data and sharing data with the Children's Institute, with the Pediatric Alliance. The study showed that inside an organization, 69% say they do a pretty good job of getting data. But when you look outside your organization, it's a much more difficult challenge. From your perspective, where are the gaps at Children's? Where's the biggest challenges, and why haven't we solved them yet?
Great question, tough answer. I'll try. It's a combination of lots of things. It could be institutional policies, regulations which are not static. You could pick the latest CMS regulations and work on it line by line, and before you know it has changed. There is a newer version. So, but I'll use another work in progress, almost completed tool that we have built locally as an example how we attack this. So we have a fairly busy pediatric practice, Kids Plus, and they use PCC as their EMR. So they do amazing care for primary care, and quite a few of their children who are seen there come to UPMC Children's. And so they wanted to get information on discharge summaries and operative notes, etc. And I can't tell those physicians, oh yeah, I'll give you access to our Cerner. That's not the way to go. That may be the easiest thing to do. But going back to the importance of workflow, these are primary care physicians who have one EMR which works for them, and they want to know how do they get information from, let's say, care in children's ER. So we built a solution called Cerner M-Page Reach in collaboration with Cerner, which is a web-based tool. And I'm going to reiterate that it's a web-based tool. So this, I don't have to worry about is the doctor's office using a Mac or a PC or anything like that. It's web-based. The easier way to describe that is Cerner Lite. And then you start from scratch to answer your question, figure out what elements are needed. I may have 100 pieces of information in the hospital Cerner EHR that's not needed for the PCP for a follow-up visit, and figure out what should be on the landing page, what should be the desirables, good to have, and start from scratch. So the challenges, the obstacles are, it's a huge laundry list, but the solutions have to be tailored to who's asking, what do they need, how much do they need, and what do they not need.
Right. Emily?
And I promise I didn't ask him to say that, but I will say thank you for M-Page Reach development. I think it's just another good illustration of how when we do something that's really good, everyone can benefit. We at IU Health are looking at M-Page Reach as a way to overcome some of what you just described, Sresh. We have people who have for years equivocated to, well, I have privileges at this hospital. I might go there once a year. And the EMR thought it was all the same. You're either a doctor at this hospital or you're not. But we don't really have the luxury of that anymore. There's not just one setting. So I would agree. Thank you, M-Page Reads. I do think one of the things, in addition to making it customized is kind of a dirty word in standards talk. So how about personal, specialized, and context appropriate has to be taken into consideration, because I really love the plumber analogy. We use that one a lot. We also use interstates, right? You can't just dump everyone's data into everyone else's data. That doesn't give you what you need. It's like data everywhere, and there's no information about what you actually need. So I think that the challenge is when we think we have different agendas to achieve, you think you want this data point. Well, we probably need to morph and have a little bit different definition of what that success of the interoperability looks like. I was thinking of some good examples where we've done this. If you think about when you go into your EMR and you can see where a patient filled a prescription, or you can see what their insurance is and which copay is going to be the least when you go to prescribe something. That is a great example of a very good use of automation when appropriate and context-driven interoperability. And that was on Chris's slide. It was SureScripts, I think, was in like the Washington area of your slide. SureScripts is the software company that makes that connections possible. But you know what else they have is a very large, very lengthy discussion about what their standards are, right? So that's a good example. We actually have a very good success story with our state immunization registry. We all agreed what they were. We agreed when a very good process for reconciling so that we don't, when we go out and I say, I'm seeing Bob Smith, I want to see Bob Smith's immunizations, they don't send me back the ones I already sent them. So kind of the rules of the road, or the rules of the plumbing's, it's not circuitry. I don't know enough about plumbing to extend your metaphor, but agreeing on what size pipes you're going to use and which way the valves goes, and all of those things are what I think are going to help us drive to that context, and therefore a very useful one. I don't think we quite have the documentation piece straightened out about which note you need when and how. I think that's harder.
That's actually interesting you bring up about the documentation piece. That's something we have a lot in Clinical Connect and DB Motion as a solution. And that's the number one spot that all of you, all you clinicians actually go to and view. So anywhere between like 60% and 70% of the time, that's where you go to get your information, which as an IT guy, I'm thinking, okay, the structured field, we've spent all this time and effort mapping out the data elements to make sure that all the diagnosis codes are the same coming from the different systems, but you're still going to this written note and reading through a document. That again baffles my simple mind.
Well, I think it's and this comes up again and again in the clinical EMR world, and I don't know if you all feel this as well, but it's kind of like when you read a really good assessment, you know whether the person put mental energy into cognitively putting that together. And I think that's probably always going to be the case. Otherwise, a robot could do my job for me, right? A robot could write my note for me, but it is that cognitive synthesis. And I like to still think like the art of telling a patient's story that's still the most valuable to us. I think I will still hold on to that forever. So I think it's one of the hardest things to solve, but then once you do, it's so valuable, right? Like I think the CCDs may be a good example. Do you guys know what I'm talking about when I say that CCD, right? Great idea on paper. Let's pull all these demographics together and send it every time a patient moves. Show of hands, anytime people have found that wildly valuable. Like, this made the difference. This prevented an extra test from being ordered, or it expedited care and a referral. I think that richness of like what we generate in the clinical narrative is still going to be, that's going to be the really the pinnacle of valuable. So
That's great. So switching to our third category around, okay, so what's the next big project? And again, single EHR was the top respondent. And maybe you can give the perspective of the entire state of Indiana with your connections. You see a lot of activity of organizations going to select a new EHR or having a single EHR?
Yeah, I think I think that we're probably starting to move past like we'll just all go on the same EHR as the solution. I think that we are now seeing a lot more clinical affiliation relationships develop, which makes sense, right? I think if you're going to I am going to buy a hospital and I will give the hospital my systems versus we're going to partner together and make sure our referrals are timely and we're going to collaborate on these cases so that we don't have 6 different heart hospitals all within a mile of each other or something like that. I like to think that that's going to drive our interoperability solutions. So we'll have more of an appropriate timeliness of exchange. I think Suresh's earlier point about access is going to do that too. Like, we use a Cerner EHR, but if you look at any of your EHRs, back in the day, there weren't that many complex positions. I don't know about all of you, but we have lots of positions trying to reflect the nuanced differences that we all play in the EMR. And I think interoperability is the same. It's not you have access or you don't. You have things like the M-Page Reach that gives you what you need to see when. And it has a lot to do with what I'm asking you to do in my system. So, at IU Health, one of the things we're working on is our referral management consistency. That does not sound glamorous, right? Referral management. I don't know that a lot of people think that's really all that awesome. But how awesome is it if we take the M-Page Reach view, and then what's the next level? Well, maybe I want to securely communicate with you in a shared message so that we can both see it in our EMRs in a secure message center. Maybe it's writing the order. I'm referring you for, now I'm going to give an adult medicine example, so bear with me. I'm referring you for endoscopy, and I need to give you some additional information. Something like a referral management platform is probably that has agreed upon rules to the shared space about what my EMR puts in and what your EMR puts in, I think is probably the way we're directed.
What do you think, Suresh?
Yes. Agree. Going back to the point of EHR consolidation, this may be a slightly different take, Emily, but Chris mentioned it. We're down to 5 EMRs. I really think that's a success. It's unlikely and also really hard and may not be cost effective to bring that down further. And I really strongly feel that switching from paper-based charts to any EMR is much easier than switching from a good EMR to another good EMR. You have to put a lot of current projects on pause for a couple of years and retraining a huge workforce, and patients will be inconvenienced when you transition from one EHR to another. So all of those need to be taken into consideration, and some large health systems have done it. They've made the commitment and they probably reap the benefits, but it's really a tough decision. And there are EHRs, Chris mentioned this, which are best of breed. They are really good for cancer care, let's say, or vision care or pediatrics. And do you stick with the best of breed EHRs for inpatient and outpatient as an example, and then try to build good interfaces? That may be the way to go. So I'm not a huge fan of a single EMR strategy. Just a personal skeptic of this. When you already have two established EMRs, and I'll give UPMC Children's as an example. We are end-to-end Cerner in the hospital. When you come to Lawrenceville, patient goes through emergency department, acute care, intensive care, operating room. Everything is Cerner. Go a couple of miles out, go into Children's Community Pediatrics practice network. 50 sites, 200 clinical providers, pediatricians and APPs. They are really happy with their Epic. And I'm happy with my Cerner. So, we are unlikely to change this. So that's a long explanation for the EHR non-consolidation. And how do we address problems within systems and different vendor systems or EHR systems, different vendor systems, one-on-one basis? And I'll give you a quick example. We have a go live next week where placing a consult order in our Cerner EHR for any service, anybody wanting to consult any service in the entire hospital will place an order in Cerner. And until now, what's happening is you have the MedTrack system, which is a couple of decades old, which is a paging system. These are two completely different systems. To get to MedTrack, you have to open up a browser, pull up cardiology service, make sure you have the right pager, and type in whatever you want to do. And we worked over the past 3 to 6 months to integrate these two. So, Rachel puts an order in the Cerner EHR. It talks to MedTrack. Thanks, Chris. And pages the right person. And that's the technical part, which obviously some work needed to be done. But there's also a bit of a culture change here. We are not used to virtual pagers. We had to convince 70 services in the hospital to get onto a virtual pager. And except for the 3 ICUs, which had good reason not to get onto this, everybody got onto it. So starting next Tuesday, we'll place an order. Sonor EHR, going back to your question, different vendor system, Medtrack, I don't know who owns it, but it's a different vendor. And they'll talk to each other, which benefits the provider. Imagine I do not have to call the operator. This has never happened in children's before. Hopefully it'll work. Go live is next week. But that's the workflow or the roadmap, I think, when you want an EHR to talk to any vendor system. It's going to be one-on-one. It's never plug and play. Even if it plugs easily, it's not going to play straight away. So you'll just have to do it on a one-on-one basis.
So that's another good transition for the next question before we open it up for some Q&A. With CMS and ONC issuing some new rules around interoperability, do you think they'll be successful?
I hope so. A lot of people hope so. CMS hopes so. ONC is hoping so. And I'll distinguish them a little bit. Both of them have a great interoperability roadmap. If you want to, you can Google and get it. And CMS is like 94 pages. ONC is 4 pages. So I like ONC. So I read that, and it has taken them a while to draft. There was a public reporting period, etc., to draft this. So a lot of good, meaningful work has gone into this. So that's why I'm hopeful of their success. They have a fairly longer time frame up till 2024. Again, lots of work to do when you have seamless interoperability where patient, whether they go into UPMC Presby or VA or wherever, can just seamlessly get all that information. And it's not only about illness. We are working in hospitals, most of us, so we think about episodes of illness. What is the encounter ID? Everything is tied to an encounter ID. But then you have to look at wellness factors. How do I get information from my Fitbit or Apple Watch here? That certainly helps. So they have addressed all these factors. So that's why I'm hopeful. I'm going to look at my notes here because I want to mention this. This is in the ONC document where they have listed all of these categories as stakeholders, individuals, as in patients, consumers, providers, should be clinicians, payers, human services, public health, researchers, and tech developers. And that's pretty comprehensive. I'm not sure if they have missed any broad category. So it's not just, okay, let's figure out how a doctor can talk to another doctor, hospital, or patient to hospital, but look at all these other various stakeholders. So I'm hopeful.
Great. Emily, your perspective?
Yeah, I don't know if it's because we're both pediatricians and we tend to be optimistic, but I would say that too. I would say, I'll do the negative piece first, right? It's big regulatory things. Suresh mentioned how long there's also infographics that are distilled down if you are a little more visual and don't want to read the whole thing like I think probably we all had to. But so I'm always a little wary when like a big law comes into what I consider kind of the clinical realm to tell us how and when to do our part. So that's my just general nervousness, because these regulations in general, I would say they really remove a lot of like you must and you shall, and they're taking off a lot of guardrails with the best of intentions, right? All of these, if you read them, there's also a theme of giving patients more access into our EMR and to their clinical data, which sounds great when you're trying to see a bunch of specialists or you're visiting from out of town and you need to show someone your medication list. Super great. Maybe not as great if you're also trying to secure parts of the chart that could be damaging to that patient. A lot of what we've talked about today is the classic rights, right? Right person, right venue, right info, right format, right time. Like those are things we always have to consider. And in the areas that we're talking about, the timeliness is everything. So really optimistic about how much power it's putting back on patients. I'll give you a concrete example. One of the things that's in these regulations is saying that we as owners of EHRs and users of EHRs have to be able to make a patient who comes up to you and says, I would like this app to pull out data installed, please. The law says, yeah, we will do that for you. We aren't the ones saying what apps patients can ask for. it's great for me as a patient. I'm doing a very broad interpretation of the law. It would be great for me as a patient, very empowering. I don't know if all of you have the same instinct of like, I can immediately think of times where that might not be serving the patient the best. Genetic tests, psychotherapy notes. There's a lot of times where the nuances of the practice of medicine don't sync up beautifully with a nice, tidy, objective role. So I have mixed optimism with some skepticism.